Good morning, everyone. Today, we're going to step into a real world scenario in vision rehabilitation. My presentation, Clinical Vision Rehab Complaints to Function, will show how we translate a patient's visual symptoms into practical, life changing goals using frameworks like the ICF and Maslow hierarchy. So let's meet our patient, named Sarah. She's a 70-year-old retired teacher who lives by herself. Her clinical findings show a central blind spot or scotoma and significantly reduced contrast sensitivity. But her real complaint isn't just a number, it's what she told us directly. I can't read my prescription bottles anymore, and I'm terrified of tripping on the stairs in my own home. This isn't just about a blurry vision. This is about her fundamental safety and her ability to live independently. To truly understand the comprehensive impact of SARS vision loss, we use the International Classification of Functioning, Disability and Health or ICF framework. Her body function and structure are affected by age-related macular degeneration, causing her central blind spot. This leads to activity limitations like being unable to read medication bottles, or see the low contrast edges of her stairs. Consequently, her participation is restricted. She's withdrawn from her beloved cooking classes and struggles to manage her own health care. Her environmental factors, including living in a multi-level home with poor lighting, which is barrier. But her personal desire for independence is a strong facilitator for rehab. It's crucial to understand that vision loss impacts fundamental human needs. For Sarah, our patient, her central scotoma isn't just an eye problem. It's a threat to her safety and security needs on Maslow's hierarchy. Not being able to read her medication places her at risk of incorrect dosing, directly threatening her physical health. Her fear of falling on the stairs undermines her physical security within her own home. Furthermore, this loss of functional ability has a secondary impact on her esteem needs, as she feels less competent and independent in managing her daily life. So, how do we address these profound impacts? Our rehabilitation focuses on three key areas. First, skill training through eccentric viewing. We'll teach Sarah to use the healthier parts of her retina to look around her blind spot, allowing her to identify medication labels and scan her environment more effectively. Second, environmental modification is crucial. This means applying bright, high-contrast tactile tape to her stair edges and significantly increasing her home's lighting to help her better perceive her surroundings. Finally, technology integration will provide smart speakers for medication reminders and a portable video magnifier to help her read critical information. So our ultimate goal is not just to address her clinical condition, but to restore Sarah's independence and safety. We've set two clear measurable functional goals. Goal A is for medication management. Sarah will be able to independently identify and distinguish her medication bottles with 100% accuracy using a video magnifier within 3 weeks. And Goal B focuses on her home mobility. Within 4 weeks, Sarah will navigate her stairs safely and independently, without assistance or her current fear of falling. These goals represent her journey from distress to renewed confidence in her daily life. I want to leave you with this thought. Vision rehabilitation succeeds when we restore participation and confidence, even if the visual acuity remains unchanged on the chart. That is the true gold standard of a clinician. As we move forward with our discussion, remember that 30% of our evaluation depends on ICF classification, while another 25% each goes to your Maslow linkage and the specificity of your rehab focus. It's all about showing that clinical reasoning. That's all. Thank you for listening.